Welcome, I'm Terry Tropin, and today I'm presenting a lesson on the CPT's Global Surgical Package. First, let me introduce myself. I have a Master's in Healthcare Administration Informatics from the University of Maryland Global Campus and have RHIA and CCSP certifications. Also, I'm an AHIMA-approved ICD-10 trainer. I have taught health information technology at Montgomery College in Maryland for over 20 years. I've also written books on coding. These books are study guides that summarize the confusing coding guidelines. My books include one on E&M coding, ICD-10-CM coding, PCS coding, and external causes. These are available on Amazon. First, here's a summary of this video. I'm going to talk about the CPT Global Package, the Medicare Global Package, what's included, what's not included, how are they different, how to pull out services from the Global Package using modifiers, and I'll briefly discuss the National Correct Coding Initiative. Let's start with the CPT Global Package. For a global package, one code is reported for the surgery itself, but it also includes other services, routine services. Now you can find this list in your CPT book in the surgery guidelines. It's called CPT Surgical Package. And this lists the services that are included and not included. So included are routine preoperative services, intra-operative services that are part of a larger services, routine post-operative services, writing physician orders, and evaluation of the patient in a post-anesthesia area. These are sometimes referred to as bundled into the surgical code. This means you cannot report separate codes for these services. They are part of the surgical code and included in the payment for the code. Here's a closer look at these bundled services. Note that these are routine services, meaning they're performed in almost every case. When this service is provided, when this procedure is done, these are included. For example, routine pre-op services, including bringing the patient in to sign consent forms. Imagine a physician skipping this step. No, I don't think so. So this is assumed that it's always done. The pre-op history and physical examination, cleansing, shaving, prepping the patient's skin, and draping and positioning the patient. These are all routine services included in the surgical code. Some routine preoperative, intraoperative services are also included. These include incision and closure of the wound, opening the patient, closing the patient, inserting intravenous access for medication, administering sedatives, and administering anesthesia. Some routine post-operative services are also bundled in. These include a wound check to evaluate the healing process. This may be in the hospital or afterwards. In the physician's office, discussion with patient about caring for the wound, documentation of post-operative physician orders, evaluation of the patient in post-anesthesia recovery area, and typical post-operative follow-up care, such as removal of sutures. So how do you know if something is bundled into a surgery code? Well, CPT indicates this in 3 different ways. Adding the words separate procedure in parentheses after a code description, parentheticals following a code description, and also notes in the introduction to a section. And I'm going to talk about each of these. Separate procedure are words that are part of the code description. These are procedures that are incidental or minor compared to a more major related procedure performed at the same session. If a separate procedure code and a related procedure are performed at the same session, report only the related, bigger, major procedure. Here's an example using breast biopsy code 19100. So breast biopsy 19100, biopsy of breast, percutaneous needle core, not using imaging guidance, separate procedure. So if the breast biopsy is performed by itself, you're going to list 19100. That's it, no modifier, nothing. On the other hand, if the breast biopsy is performed on the same day as a radical mastectomy, such as 19305, you're going to list only 19305. The biopsy is not coded. It's a separate procedure and obviously minor compared to a mastectomy. Parentheticals are another way that CPT indicates that services are bundled. This is a note under a code description, sometimes indicating that codes are bundled. These are called parentheticals. They're in parentheses. So here's an example. 22015, incision and drainage open, lumbar sacral or lumbosacral. Under that code is a parenthetical. Do not report 22015 in conjunction with 22010. That just means, I don't know why they put in the in conjunction, but don't code this with this. So that's another way to say these are bundles. So you choose one, 22015 or 22010. Introductions to sections are another way that CPT indicates bundling or inclusion of services in another. For example, in the integumentary system, the subsection excision benign lesions states, excision, including simple closure of benign lesions of skin, includes local anesthesia. This means that the simple closure is included in these codes, bundled into these codes. There are codes for simple closures, but you can't report those with codes in this section. Remember, we said that services are bundled, included in the main surgical code if they are a routine part of the surgical codes. But some services are specifically not bundled. In this picture, these are represented by the small packages around the bigger red package for the global. So this is the global, and these are all the services that are not bundled into the global package. So what kind of services are we talking about? We're talking about initial consultation to determine the need for surgery. The E&M service when the physician says, we need to do a surgery. Visits unrelated to the diagnosis for the surgery. Services provided by other physicians, and the physician or the physician practice owns the global package. If someone outside that practice provides a service, that's completely different. Diagnostic tests and procedures are also outside the global package. Separate codes can be reported for these post-operative services. Clearly distinct surgical procedures not for treatment of complications, so for a different, done for a different reason. Post-operative treatment that requires a return trip to operating room. This is like for a complication. Physicians don't like to use that word, but it's a complication. A more extensive procedure, if the original procedure has failed, this can also be reported separately. Here is a practice. The physician performed a uterotomy with drainage 50600. He also inserts a stent into the ureter 50605. How is this coded? Here's a hint. 50600 is a separate procedure code. So knowing that, can both codes be reported? No, only the 50605 is coded. These procedures were both performed on the ureter, and so the uterotomy is bundled into the insertion of stent. Here you go. Now, Medicare has a slightly different definition of a global package. The differences are not huge, but they can be very important. Remember that if it's not included in the global package, you can report and get paid for it separately. The most important thing is that Medicare divides all surgeries into either minor surgeries or major surgeries. A minor surgery, removal of skin lesion, a biopsy, something like that. A major procedure is a bigger, more invasive procedure, a hysterectomy or a bypass, for example. A major procedure has a 90-day post-operative period. This means that routine services provided after the surgery are included in the surgical code for 90 days, beginning the day after the surgery. These cannot be reported separately. There are two types of minor procedures. There's a minor procedure with a 10-day global period and a minor procedure with a 0-day global period. So for the 10-day global period, these are routine services for 10 days after the surgery, beginning the day after the surgery. That's when you start counting. A minor procedure with a 0-day global means that it's only the services provided on the same day as the surgery, the routine services. Beginning on the day after, you can start to code. What if a service is provided to a major procedure 95 days after the surgery? This can be reported separately since it is past the 90-day period. What if the service is provided for a minor procedure the day after the zero? For a 0-day service, this can also be reported separately. Now, if an audit shows that the provider is routinely seeing the patient for routine services a few days after the global period ends, there will be problems. So you don't want to wait till day 11 on a minor procedure just so it can be reported separately, particularly for Medicare, which frowns upon this very strongly. Here's a summary of the differences between CPT and Medicare global packages. So E&M services during which the physician decides this patient needs surgery, these are not included in either global package. Specific global surgical days for post-operative routine services. Medicare has specific days. CPT does not. It just says typical post-operative care, but doesn't give a specific number of days, 90 days, 0 days, 10 days, whichever. Local anesthesia is included in both. General or regional anesthesia, this is one of the ways that it varies. This is not included under CPT, but is included under Medicare. So this is one that's different. Post-operative return to the operating room for a related condition, not included, can be reported separately. And you see it lists here modifiers, and we're going to talk about those in a minute. Post-operative return to operating room for related procedure, such as a complication, not included. These can also be separate. Post-operative complication, not requiring a return to the operating room. This is another variance. For Medicare, you can't report a post-operative complication treatment unless it's returned to the operating room. For CPT, you can. So this is another one that's different. An unrelated E&M service during the post-operative period for a condition not related to the reason for this surgery or for a treatment of a complication. This is not included. So we see the differences are this one and this one and this one, specific global days. So one of the problems with this is that we know what Medicare says, but CPT and Medicare are not always followed. So you have some commercial insurers use some of the Medicare rules, but not all of the Medicare rules. Or they could use all the Medicare rules. It varies. For example, many commercial insurers like the global period designations, the specific days for Medicare and will use these for all of their patients. So that varies. So here's a practice. Dr. Cook performed a pulmonary valve replacement on Mrs. Jenkins a week ago. Mrs. Jenkins is now seen in Dr. Cook's office for a dehiscence of the wound. Dr. Cook performed a repair of the wound with packing in his office. Mrs. Jenkins is 24 years old, so we're going to assume that she's not covered by Medicare. So under CPT rules, you can report this separately, 12021, for the wound repair. Medicare doesn't pay extra for post-operative treatment that doesn't require return to the operating room, but other insurance may. CPT rules say that you can report this separately. Now, sometimes modifiers are used to indicate that services provided in a specific case should not be bundled, but should be paid separately. The important thing to remember is if it's appropriate to use a modifier, if it's appropriate to report it separately, if you don't use a modifier, it will not get paid. Some modifiers are used with surgical codes, while others are used with E&M code. For surgical codes, we're going to talk about 58, 59, 78, 79, RT, LT. For with E&M codes, we're going to talk about 24, 25, and 57. These modifiers are added to CPT codes with a dash, such as 49000-58. We will discuss each of these modifiers. First, let's talk about modifier 58. This is added to a surgical code. This is for a post-operative procedure, for a procedure that is related to the original procedure. It may be a procedure that was planned, staged, done in stages. It may be more extensive than the original procedure, or for therapy following an original procedure. An example is multiple skin grafts completed in several sessions. The global period starts after each new procedure. So if the original one was a 10-day procedure, and then at day 6, the post-operative procedure related to it is done, that the global period starts over again. If the second one is a 90-day procedure, you start the 90 days then, even though the original 10 days has not been completed. So modifier 59 is also added to a surgical code. This is the most confusing modifier, I think. It's used when to indicate a service is separately reported in this case because the two procedures involved a different session or encounter, a different site on the body, or through a separate incision or excision involves a different lesion, or a different injury, or different areas if you're talking about extensive injuries. These are added when a procedure is usually bundled, but in this case you're saying, no, wait, don't bundle these to the insurance company's computer. Now, if there's another modifier that would work better, that would also be appropriate, use that one instead. And we'll talk about that in a minute too. So here's an example. Modifier 59, which is titled distinct procedure, is added to the procedure that would normally be bundled into the other procedure done at the same time. So here's an example. Perform these procedures on the left foot. So you have an ostectomy, 28110, partial excision, 5th metatarsal head, and this is a separate procedure. The other procedure performed is a complete excision, but it was the first metatarsal head, 2 different bones, okay? But this is a separate procedure, so you do 28111 and 28110-59. If you don't do that -59, they will not pay you for the 28110. They won't be paid. If possible, link them to a different diagnosis, but the 59 will kick it out of the computer and have somebody, a real person, have to actually look at it. If the modifier was not added, the insurer would pay only for one of the codes, the 28110. So that's why this is really important. Why modifiers are really, really important. On the other hand, if the physician documented these procedures on both of the left foot, 28114, complete excision, all metatarsal heads, and 28110, partial excision, fifth metatarsal head. These are both on the same foot. Well, partial is included in complete. Fifth metatarsal is part of the all metatarsals, so you would report only 28114. It would be inappropriate in this case to use a modifier 59. Modifiers RT and LT are also a way to pull services out of a global package. These modifiers can only be used for identical body parts. You have 2 eyes, 2 ears, 2 lungs, 2 kidneys. The modifier cannot be used for the right and left side of one organ, such as the right side of the lung and the left side of right side of the heart and left side of the heart. Can't do it. You've got to have 2 identical organs in the body. Here's an example similar to the previous ones on foot bones. In this case, see the position documented on the left foot, 28114, complete excision, all metatarsal heads, and then on the right foot, partial excision, fifth metatarsal head, and this is a separate procedure. So these are different sites, so therefore it's legitimate to report both of them. So do 28114-LT and 28110-RT, and that will differentiate that they indicate that they are 2 different sites, and it is appropriate to report both of them, even though 28110 is a separate procedure. If you don't use the LT-RT, the insurance company will not pay for both. So that's, again, why these are so important. So let's look at surgical modifier 78. This is also added to a surgical code for a post-operative procedure performed to treat a complication of the first procedure. And it includes a return to the operating room. You'll remember we talked about Medicare and compared CPT and Medicare global packages. That's why this is important, whether or not the patient was returned to the operating room or not. So a patient had outpatient procedure in the morning, was returned to the operating room in the afternoon with hemorrhage. This does not change the global period. So if the first procedure had a 10-day global period, it goes back to the operating room. It doesn't change that initial, you still stick with that initial 10-day period. So here's another practice. Mr. Mitchell had hip replacement surgery performed by Dr. Weiss. 2 days post-op, this incision developed a hematoma. This required a return trip to the OR where Dr. Weiss performed a superficial wound adhesions with a simple closure, 12020. What modifier, if any, should be used? I'm going to use the 78 on this. This was a complication of the hip replacement surgery. If you did this without the modifier, it would not be paid, but it is legitimate that this be reported separately. Modifier 79 is also added to a surgical code. It is used for a post-operative procedure condition unrelated to the first procedure. So several days after discharge for a procedure, the patient returns for an unrelated procedure, had nothing to do, not related to the wound or the actual reason, the diagnosis for the original procedure. So it would have a different diagnosis and a new global period starts. Okay, but again, if you don't have the modifier, it's not going to be accepted, not going to be paid. So here's another example. Mr. Duncan underwent an excision of 2 lesions on a small intestine by Dr. Case. 30 days stop, Mr. Duncan was experiencing pain in the area of the diaphragm. Several tests were done and a diaphragmatic hernia was diagnosed. Mr. Duncan underwent surgical repair of a paraesophageal hiatal hernia via using thoracotomy. This is 43334. So think about it. Okay. So in this case, you're going to do 43334-79. The hernia repair is unrelated to the excision of lesions, but is during the global period for 43334. So therefore, you need the modifier 79 to pull it out of that global period to get it paid separately. So let's look at modifiers 54, 55, and 56. These modifiers are used when the physician does not provide all of the global package, when they provide some of it and then it's transferred to someone else. Modifier 54 is providing only the procedure itself, the intraoperative care, not the preoperative or the postoperative. If the physician provided only the preoperative care, you're going to use modifier 56. If the physician provides only postoperative care, you have modifier 55. Modifiers 54 and 55 are used when a transfer of care has taken place. One physician provides part of the surgical package and then transfers the patient to another physician from another practice. If the services were provided by different physicians within the same practice with the same tax ID, you're going to report only the surgical code. The practice is one entity. CMS guidelines, Medicare guidelines state, use these codes only if a transfer of care has been documented. If not, use an E&M code instead of these modifiers on the surgical code. If the services are follow-up services for minor procedures performed in emergency departments, or if the services are provided during a post-operative period for an underlying condition or medical complication. A lot of insurers don't accept 54, 55, 56, so you need to check on that. So for modifier 56, preoperative management only, CMS says, nope, we don't accept this. Don't use it. So you're going to use an E&M code instead. Other payers, as I said, may or may not accept this. Now let's talk about modifiers that are added to evaluation and management E&M codes, not surgical codes. The first one we're going to talk about is modifier 24. This is for an E&M service not related to the surgery during the post-operative period. So for example, a patient is in a global period for hip surgery, but is now seen for possible pneumonia. Well, the pneumonia is not related to the surgery or the reason for the surgery. So you do the E&M service to evaluate the pneumonia, but you put a modifier 24 on it to pull it out to say this should not be part of the global package. The next modifier is 25. This is used for an E&M service provided on the same day as a procedure. For example, a patient comes in for sinus congestion, provider performs a history and physical, provides a decongestion, and while they're doing an examination says, oh, there's a lesion on the back. Want to remove that today? And the patient says, yes, let's do it. So in addition to providing the removal of the lesion, the procedure code for that, you add a modifier 25 to the E&M code. Another example is a patient seen on consultation for pain management. Before providing the opinion, the physician is given a nerve injection. So you have an E&M code for the consultation and a procedure code for the injection, but you add a modifier 25 to the E&M code. Modifier 57 is used when a physician performs an E&M service and decides to perform surgery either that day or the next. So the patient comes in and says, I have X condition or X problem. Physician does an examination and says, you know what, we're going to need to do a procedure. So that E&M evaluate the patient's condition is reported separately with the 57 modifier. Remember that the global package includes related services the day of or the day before the surgery. So the global package is assuming that an E&M service before the day before surgery is the signing consent, that kind of thing. Well, that's not what it is. This is different. This is deciding, hey, you need surgery. So this modifier pulls the service out of that package. So here's an example of modifier 57. Patient seen for throat pain. Physician does an E&M service and then performs an endoscopic removal of the foreign body from the esophagus. Yow. List code 43020 for removal of foreign body, and also the E&M code for the evaluation that was done with the modifier 57. So you'll notice that modifier 57 and modifier 25 sound really familiar. So when do you use one and when do you use the other? Modifier 25 is usually done for minor procedures on the same date. Injections, skin repairs, minor kind of procedures. Modifiers 57, on the other hand, are major procedures, same day or day before. Usually, they're 90-day global procedures. Not always, but usually. So that's the difference between modifier 25 and 57. Here's a summary of the modifiers we've talked about. Timing is important. Modifiers 24, 58, and 79 are used for services provided in post-operative period. Post-operative, post-operative, post-operative. Modifiers 25, 57, 59, LT, and RT are same day or next day. Same day, same day, same day, same surgical session. The final column indicates the relationship between the procedures. Is the second service related to or not related to the original service? This is not related. It's related, complication, original, unrelated, and unrelated. So very important to differentiate between these. In addition to the bundling issues we've discussed so far, Medicare has something called the National Correct Coding Initiative. This lists codes and other services that are bundled into them. It's a list of codes that cannot be reported together when provided at the same time, same patient. So CMS, Medicare, has stated that we developed the NCCI to promote correct coding methodologies and control improper coding leading to inappropriate payment. So the NCCI starts with CPT coding guidelines and talks about, and then expands to national local policies, things that other insurers use, coding guidelines developed by national societies. Like I used to work for the American College of Obstetricians and Gynecologists, and they had coding guidelines that they had developed, and so it uses those. It also looks at payments and what has been, what services are often reported together, and looks at whether or not those should be reported together. Part of the nightmare of NCCI is that it is updated quarterly. So this means that codes that were bundled in January may not be bundled in May. So they come out with this huge file, computer file, quarterly with changes. This is a subject that with its own video, so I'm not going to go into a lot of detail on it in this video. You can find more information at the site listed on this slide here. It is impossible to remember all the guidelines for coding. This is why it's so important to make notes in your book. First, look at the guidelines for surgery in your CPT book and circle the surgical package definition. This is the services that are included, but you might want to write in the services that are not reported separately, the things that can be coded and paid for separately. You might also want to write in information about the global periods. Then turn to Appendix A, which is for modifiers. You can write in next, used with E&M codes 24, 25, and 27, write in used with surgical codes next to these modifiers. So it's easy to differentiate, oh, this one's not used with surgical, this one is used with surgical, and so that will help you differentiate at a glance between the different types of modifiers. Look at modifiers 24, 56, 58, 78, and 79 and underline the word post-operative. These are only used for post-operative services. You might also make a note the difference between modifier 25 and modifier 57. And write in a note about modifiers RT and LT. That completes this lesson. If you have questions or comments, please feel free to contact me. Here again are the books I've written on coding. These are available on Amazon. You can go here, or you can just go to Amazon Books and type in my last name, Tropin. Please click on my picture to subscribe to this channel. I'm posting a new video about once a week, so don't miss out. And if you have questions, contact me here. If there's something in particular you'd like me to do a video on, let me know. I'd love to hear from you. Thank you so much for listening. I hope this was helpful. Thank you.